All right, now I'm going to be recording about cystic fibrosis. So if you don't have your handout and your book open to page 747, you need to do so now. All right, we'll get started. If you have any questions or concerns, please let me know. Thank you. All right, fast fact sheet, cystic fibrosis, 747 through 754 in your Peds book. Now, this is an autosomal, means both parents must pass on the defective gene to the child in order to cause it, that causes dysfunction of the exocrine glands. Now, by doing that, what happens is the goblet cells of the mucus-producing cells have this production of thick secretions. So usually they're these very thin, free-flowing secretions. But what happens when you have this autosomal recessive disease, everything thickens up and causes lots of obstructions. And there is no cure. This results in tenacious mucus production that obstructs vital organs. And it talks about this on page 748. You can see the diagram of the various effects of exocrine gland dysfunction in cystic fibrosis. So you start out with your basic defect at the top. Your exocrine gland dysfunction causes abnormal mucus secretion and obstruction in the bronchi, the small intestines, the pancreatic ducts, the bile ducts, and I would add sweat glands and reproductive system because it also affects those two systems as well. Now, what happens is if they affect the bronchus, it leads to bronchial obstruction so that you end up with chronic bronchial pneumonia. You end up with obstructive emphysema. In the small intestine, failure to pass meconium, so you end up with intestinal obstruction of the newborn. Pancreatic ducts can cause secondary degeneration of the pancreas so that you end up with an absence of pancreatic enzymes and malabsorption syndrome. The bile ducts can be clogged, causing biliary cirrhosis and leading to portal hypertension. Now, again, it can also affect the sweat glands so that you sweat. A lot of the sweat comes out in the skin. And then it also affects the reproductive system, which we'll talk about in a little bit. Now, there are multiple problems that can result from the exocrine dysfunction, such as lung insufficiency, which is the most critical and the one we're most concerned about. Pancreatic insufficiency, I already talked about the enzymes being deficient, and increased loss of sodium and chloride in the sweat. So those are the three main things that we've got to home in on because that's where we see the multiple problems occurring. So when we get ready to do our handy-dandy assessment, this is usually found in Caucasian infants and children. And meconium ileus at birth is a big thing. This is a big cardinal sign if they have a meconium ileus. And this occurs at least in 20%, and that's why we still check for CF. Now, there is a complete list of clinical manifestations of cystic fibrosis on page 749 in your book, and it goes over these. It talks about abdominal distension, vomiting, failure to pass stools, and rapid development of dehydration being common signs and symptoms of meconium ileus. You need to know those. Then it talks about gastrointestinal manifestations you may see. Very bulky, loose, frothy, foul-smelling stools, and that's because of steatorrhea, the blockage of the pancreatic enzymes. They may have a voracious appetite, loss of appetite later on, weight loss, tissue wasting, failure to thrive, distended abdomen, thin extremities. You may see wheezing, dry, non-productive cough, and eventually they can get into shortness of breath, atelectasis, and then as they get into the chronic stage, they get the barrel chested, the cyanosis, the clubbing, and the repeated episode of bronchitis. As far as other things you're going to see recurrent respiratory problems. They have respiratory infection after respiratory infection, pulmonary congestion, steatorrhea, excessive fat, greasy, foul-smelling stools, delayed growth, and poor weight gain. And skin, again, that tastes salty when they're kissed. That's a big red flag. And again, later you'll see stenosis, nail bed clubbing. If you don't know what that is, you need to look it up. And cystic fibrosis can actually lead to congestive heart failure, where death is usually caused by cardiac and respiratory insufficiencies. Now, this is the earliest manifestation in CF, and I've already talked about that because the small intestines become blocked with thick putty-like meconium. Now, why is there such a wide variety of signs and symptoms in cystic fibrosis children? Because if you were to line them all up, they would all have different signs and symptoms. And the reason that is because there's over 500 mutations of the gene that are present. Now, unfortunately, the mean average age right now of life is about 37.7 years. And that's because it's so hard to diagnose because it's related to a lot of other diseases that it's a lot of times takes a while to find it. And by then they've done some damage. So you need to read over pages 747 through 749 in your book. Now, as far as nursing diagnosis, the big ones are ineffective airway clearance and imbalanced nutrition for these children. Diagnostic, they're going to do a stool analysis. They're going to check for pancreatic enzymes. They're going to do pulmonary studies like chest x-rays. They're going to do what's called the sweat test, which is the simplest and most reliable method, and we'll talk about that in just a minute. And then listen for complaints of a parent saying they have salty tasting skin. Now, what they do with the sweat test, and I have also put a YouTube, you need to watch this, and on page 749 gives you more details as well. They will put a gauze pad or a piece of filtered paper on the child's forearm to collect sweat. Then the area to the arm or back is wrapped in plastic. The sweat glands are stimulated to sweat using a harmless chemical, pilocarpine, and a very small amount of electricity. Yes, it sounds like a science fair project, but it's not. After several minutes, the pad is removed and sent to lab. If greater than 60 milliequivalents per liter is present of sweat of sodium chloride, then it is considered positive, okay? If it's between 50 to 60, it's suspicious, and 50 or less is considered normal. So 50 or less is normal, 50 to 60 suspicious, and over 60 is positive. Again, I have a YouTube video. Please watch it. Nursing plan of care, you're going to monitor their respiratory status, assess for signs of infection. They're going to be on antibiotics, and a lot of times they're on so much vitamin K it wipes out their normal flora along with these antibiotics, and they end up with other issues. You want to administer IV antibiotics as prescribed. They're on large doses. They've got because they're on vitamin K and they have an increased metabolic rate. You want to administer pancreatic enzymes like your pancrease, your Vicase powder. These are pancreatic enzyme replacements. If they're an infant, you can put them in applesauce, rice, cereal for older children with food, and it helps improve the absorption of proteins and fat in that meal that they eat. Well, how much? Well, the answer is depends. Now, it is given with meals and snacks, but it can be anywhere from 1 to 5 caps with meal, depending upon how well the child's doing, and 1 to 2 caps with each snack. And again, that varies patient to patient. Some patients may only have to take 3 caps with meals and 1 with snacks. Someone may be maxed out at taking 5 capsules of pancreatic enzyme replacements with every meal and 2 with every snack. It depends upon how well they're absorbing. Now, it depends upon their growth patterns and the characteristic and number of stools. So 2 days desired that don't float. So if you give them, you want them, in other words, you don't want them, you want them to have sinkers, not floaters, okay? You want them to be able to have stool that's not floating around and fatty and absorbent. You want it to be a sinker. So think of fishing like that. You throw it out, you know, the sinker goes to the bottom, okay? In this case, you want sinkers, not floaters. Administer fat soluble vitamins A, D, E, and K, and you're going to absorb that, and those are your water soluble forms. And usually they take those about twice a day. Administer oxygen and nebulizer treatments. One of the newer meds is DNase, and that's a med that decreases the viscosity of mucus by acting on the DNA in sputum, so it makes it to where it's a little thinner. It's inhaled through a special nebulizer device, and some of the side effects of that is like voice alterations and laryngitis. Evaluate the effectiveness of treatment is a big thing. You always want to do that. It talks more about that on page 750, and there is a nursing alert. Signs of a pneumothorax are usually nonspecific and include tachypnea, tachycardia, shortness of breath, pallor, and cyanosis. A drop in O2 sat measured by an O2 oximetry may be an early sign also of a pneumothorax, so remember those. You want to teach the patient percussion and postural drainage techniques. And don't forget to use the teaching learning principles that you've learned about. That's assessing the level of knowledge. How much do they have? How much do they know? How do they learn best? Are they motivated? Do they have barriers to learning? You want to teach dietary recommendations also as well. A hint, the child will need 150% of the usual caloric intake for normal growth and development to occur. So they'll need the full amount plus 50% more. It is not unusual for these children to take in 3,000 to 5,000 calories per day. They are breathing harder, they're having more infections, so they have increased metabolic needs. They need a high protein diet, twice the normal requirements. So infants, if it's an infant, they need a high protein formula. They need a moderation in fat, but they do need fats. A moderate amount of carbs. Usually they're high and simple, low and complex. An increase in, and that's because they're easier to digest, an increase in sodium. 2 to 4 grams a day to offset the loss, and dietary iron is increased, and that's because of the deficiencies in pancreatic enzymes related to its absorption. You want to provide age-appropriate activities for these children and refer the family for genetic counseling for inheritance pattern. One of the things you want to remember, again, it's an autosomal recessive disorder. Both parents have to have it in order for the child to have it. That means that it shows the typical autosomal pattern that the child will have a 50% chance of being a carrier. They'll have a 25% chance of having CF, and they'll have a 25% chance of being normal. So, what if it's hot outside? What if that sun is beaming? Then you're going to have to teach them increase fluids, increase salt. Easy way to do that, pretzels, crackers, something salty, okay? Because they're already losing a lot of salts. So you've got to replace that sodium and those electrolytes as well. Is there any restriction on activities? They can swim. They can do some sports, races. It varies depending upon their toleration of the child and the level of the disease progression. So that answer simply depends. What's new? There is a new Flutter mucus clearance device. This is a small handheld device that looses secretions. It's got a picture of that on page 750 in your book. And I've also put a YouTube for you to view that. The therapy vest is also a new thing. I have put a YouTube, and I would suggest you watch these. They're looking at doing lung transplants on these children, and they have had some success with that. Genetic therapy, they're looking at doing genetic or gene therapy. And then community support. There is a cystic fibrosis pharmacy specifically made for children and adults with cystic fibrosis in Orlando, Florida, that does nothing but specialize in cystic fibrosis medications. There are also chapters throughout the United States. And again, I've got you a YouTube here that you will need to watch. Watch all my YouTubes. Transitioning to adulthood, it talks about that in the book because a long time ago they didn't live this long. But now that they're living to a mean age of 37.7, we do have to give them some supportive care during the adult years. If I refer you to the pages in the book, please read them and please refer to the websites or the web YouTube connections and watch them. This content will be on the exam. Thank you. Oh, and one of the last things I wanted to say is about reproduction. Let me go back to that before I finish. In the reproduction system, you've got to be very careful. A lot of the males are sterile. The females, a lot of them think they're sterile, but they do have the chance of still thinking they're so sterile that they don't have to worry about pregnancy. Then they end up with a lot of STDs. So you've got to make sure, not all, I'm not saying all, but some end up with STDs. So you want to make sure that they understand that, yes, you may be sterile, but while you're sterile, you still have to be use protective. You also have to be protective when you're having sex because you don't want to get STDs. Now, also, you want to make sure that you are assessing their level of knowledge. What do they know about cystic fibrosis and how it affects a reproductive system? All right. Thank you. Have a great day. If you have any questions or concerns, let me know.